Well, it's a pleasure to be speaking with you today about the treatment and prevention of monkeypox. These are my disclosures. By way of brief overview, remember that monkeypox is a member of the orthopox genus of viruses belonging to the Poxviridae family. It's closely related to smallpox, also known as variola, cowpox, vaccinia, canarypox, etc. And you can see in this phylogenetic diagram just how closely related these viruses are. Therefore, it's not surprising that therapies that are effective against one of the orthopox viruses is likely to be effective against several of the others. And recall that vaccinia is actually a cowpox virus, and that it was the observation that people who had exposure to cowpox were protected against smallpox that led to the adoption of vaccinia as a vaccine for smallpox. Therefore, it's appropriate that we consider the use of smallpox vaccine for the prevention of monkeypox, a related orthopox virus. Well, what's the current status and treatment for treatment and prevention of smallpox virus? There are currently 3 US FDA-approved drugs for the treatment of smallpox virus: tecovirimat, cidofovir, and brincidofovir. And there are 2 US FDA vaccines approved for prevention of smallpox: ACAM 2000 and the Jynneos vaccine. Now, approval of these drugs or vaccines has been based on the animal rule. This allows approval of drugs for human use based on results of appropriate animal trials when clinical trials in humans cannot reasonably or safely be conducted. Prior to the current monkeypox outbreak, experience with these agents for the treatment and prevention of monkeypox was really scant. So let's talk first about treatment. So tecovirimat, which is known by its trade name TPOXX and was previously known as ST246, was approved for the treatment of smallpox in 2018. It targets a viral protein called VP37, which is required for envelopment of intracellular mature virus, shown in this diagram as IMV, by Golgi-associated membranes to become intracellular enveloped virus, a necessary step in the egress of pox viruses. And it's broadly active against members of the Orthopoxviridae genus. This slide taken yesterday from a search on PubMed shows how, beginning in 2005, when there was a single publication on tecovirimat, to just the first several months of this year, where there are now 27 publications, you can see how interest in this drug has really blossomed. The data on which the FDA approval of tecovirimat for treatment of smallpox is shown from this New England Journal of Medicine paper published now 4 years ago. And it was based on data from both rabbit and monkeypox models. So that is rabbit pox virus in rabbits and monkeypox virus in non-human primates, remembering that monkeypox virus is not really a virus of monkeys. These are dose response curves being shown. If we focus on the right-hand column, which has the higher doses, you can see that for the monkeypox lethal challenge experiments, that doses of 3 milligrams per kilo and above were completely protective against mortality. And likewise, in the rabbit model with rabbit pox virus, doses of 120 milligrams per kilo were fully protective. In addition to the animal model study, human PK data studies were done in order to determine appropriate dosing in people and safety. These were studies of about 400 or so people exposed to tecovirimat and placebo. You can see there was really no difference in the rates of adverse events or in study drug discontinuation. Well, what has been the human clinical experience with tecovirimat? To date, most of the experience with tecovirimat has been in the treatment of severe or disseminated vaccinia virus infection. I'll show you a couple of examples of that. This was true even when tecovirimat was still an investigational agent. It was being used through emergency investigational drug use for select cases. But there has been accumulating anecdotal experience in the treatment of monkeypox infection since the current outbreak was first recognized in the late spring of this year. There is currently a randomized clinical trial being sponsored by the National Institute of Allergy and Infectious Disease, being conducted by the AIDS Clinical Trials Group. This is a study that will have two components, a randomized placebo-controlled group for those with less severe infection, and then an open label arm for people with severe infection. I'll speak only briefly about cidofovir and brincidofovir because they're not widely used, and brincidofovir at the moment is not actually available. These are both phosphonate nucleotide analog inhibitors of DNA polymerase with broad activity against double-stranded DNA viruses. Cidofovir, of course, is used widely for the treatment of valganciclovir or ganciclovir-resistant CMV. It also has activity against adenovirus. And then brincidofovir was used in the recent Ebola outbreak, and it has also, both drugs have been shown to have activity against orthopox viruses. They are both approved for treatment of smallpox under the animal rule, and there's a very interesting paper by Chentak et al. From the FDA explaining the rationale for approval of brincidofovir for treatment of smallpox. Cidofovir has to be given intravenously, and it has dose-limiting nephrotoxicity. Whereas brincidofovir is orally bioavailable, it's a prodrug of cidofovir with reduced nephrotoxicity. Phase 2 trials showed a reduced risk of CMV in stem cell transplant recipients with brincidofovir, but then the phase 3 studies in the stem cell transplant population showed excess mortality, and so the drug is no longer being developed for either CMV or adenovirus. But there have been anecdotal reports of its use in the treatment of disseminated vaccinia and now monkeypox. But its current availability is actually limited, as I mentioned. That's because the company that was initially developing it licensed it to another company after receiving FDA approval, and there are now negotiations ongoing to deposit brincidofovir in the United States strategic national supply. Well, what are the current guidelines for treatment? The CDC has issued interim clinical guidance for the treatment of monkeypox. And these include people with severe disease, that is severe systemic involvement with monkeypox, people who might be at risk of severe disease, including those who are immunocompromised, pediatric populations, particularly those under age 8, people with a history of atopic dermatitis or exfoliative skin conditions, because we know they are at risk for disseminated poxvirus infection, and pregnant or breastfeeding women. In addition, people who have one or more complications of monkeypox, as well as people with monkeypox in locations that are particularly sensitive, and that includes infections in or near the eye, the mouth, and other mucosal locations like the genitals or the anus. This slide summarizes tecovirimat prescribing information. The dose is 600 milligrams twice daily. The drug is available as 200 milligram capsules. There are dosing algorithms for based on weight for pediatric dosing, and the capsules can be opened so smaller amounts of drug can be given. In addition, there is an IV formulation available for people who are unable to take oral medications. In terms of adverse reactions, headache and nausea are the most common. A single study participant was found to have neutropenia, and then the intravenous infusion is associated with pain in a majority of patients and may have some local swelling and erythema as well. There are some cautionary notes about the use of tecovirimat. It should not be given to people with severe renal impairment, that is a creatinine clearance less than 30 milliliters per minute. And it should be used with caution in persons with mild to moderate renal impairment or in children under 2 years of age. Tecovirimat is a weak inducer of CYP3A4. Because it's only given for 14 days, this shouldn't cause significant problems, although there are cautions about its use with certain antiretroviral agents, including rilpivirine and atazanavir. Well, let's turn now to prevention. As I mentioned, there are two vaccines to prevent smallpox that are currently approved in the United States. ACAM 2000 is a replication competent live virus vaccine. The main concern about this vaccine, which has much wider use to date than the Jynneos vaccine, is the risk of eczema vaccinatum in persons with atopic dermatitis. It's the potential for dissemination in immunocompromised patients and a low but notable incidence of myocarditis. Animal models have shown protection against monkeypox, but there are no human data on protection so far. The Jynneos vaccine is a replication deficient or defective live virus vaccine. There is no risk of dissemination with this vaccine. And again, animal models have shown protection against monkeypox, but there are no human data. So why would we use a smallpox vaccine to prevent monkeypox? Well, retrospective data correlating a rise in monkeypox cases in the Congo after the cessation of smallpox vaccination suggest a protective effect of smallpox vaccine against monkeypox. And this slide shows these data. Here you can see the incidence of monkeypox in the Democratic Republic of Congo by age group. And of course, the youngest people were never vaccinated against smallpox, but in the older age groups, there were both vaccinated and unvaccinated individuals. And if you look at the incidence ratio, there's about a tenfold higher incidence in those who were unvaccinated compared to vaccinated. And this is shown more clearly in the figure at the bottom of the slide. Here we're looking at data from two periods, 1981 through 1986, and then 2006 and 7. And what you can see is in the earlier period shown in blue, that older persons, those aged 10 and over, the vast majority were vaccinated or had a history of vaccination against smallpox, and there was essentially no incidence of monkeypox infection. And then as the prevalence of vaccination tailed off, you begin to see some monkeypox cases. In the more recent time period, 2006 to 2007, where only the older age group had a substantial proportion who had a history of smallpox vaccination, you can see this very nice age-related incidence, where incidence is very low amongst the vaccinated and higher among the unvaccinated. Of course, these are imperfect data because it's not a randomized study, and you could argue that younger people were just doing different activities that made them more likely to come in contact with monkeypox, but I think these are quite compelling data. Well, how does the ACAM 2000 and Jynneos vaccines compare? As I mentioned, one is replication competent and the other replication deficient. The ACAM 2000 vaccine is given by using a bifurcated needle and puncturing the skin multiple times, as illustrated here. For those of you who are old enough to have received smallpox vaccine will remember that you essentially get scratched many times with this needle, and then the vaccine is supposed to cause a scab, which is known as a take, which is evidence of actual replication of the vaccinia virus. By contrast, the Jynneos vaccine is initially authorized or approved for subcutaneous administration, 2 doses 28 days apart. As I mentioned, there's an incidence of myocarditis of 5.7 per 1,000 primary vaccinees. There are no data on myocarditis in the Jynneos vaccine, but to be fair, many fewer people have received this vaccine. This slide shows the complications of ACAM 2000 and why the Jynneos vaccine is now favored. This unfortunate infant was actually a household contact of a member of the armed services in the United States who had received the ACAM 2000 vaccine as part of their mandatory vaccination, and the child had a history of atopic dermatitis. Very fortunately, this child recovered actually with minimal scarring. And then on the right, you see the arm of a soldier who had received the ACAM 2000. This was somebody who turned out to have a history of eczema and has this dramatic local reaction and spread of vaccinia virus, which again improves. This person received tecovirimat and brimcidofovir. Well, what are current US guidelines for vaccination? Uh, in the United States, vaccination for monkeypox is focusing on post-exposure prophylaxis. That's a vaccination of people who have a known documented exposure, either because they are aware of having been exposed to somebody with confirmed monkeypox or have been identified as a contact through contact tracing. And then there's so-called post-exposure plus or expanded post-exposure prophylaxis, which is vaccinating individuals who have either known or presumed exposure to monkeypox. And that includes not only those who've been contacted by health authorities, but people who are aware that a recent sex partner, recent being within the last 2 weeks, has now been diagnosed with monkeypox. And then for certain gay, bisexual, or other men who have sex with men, or transgender and gender diverse people who have sex with men, if they have had multiple sex partners within the last 14 days in a venue where monkeypox transmission is occurring, they may also be considered to receive vaccination to protect against monkeypox. Pre-exposure prophylaxis is currently only recommended for certain occupational risk groups, which really means individuals who are actually doing diagnostic testing for monkeypox virus infection or are working with monkeypox and vaccinia, not regular healthcare workers. And so this slide shows some additional details on the CDC guidance when being given for post-exposure prophylaxis. Ideally, the vaccine should be given within 4 days of exposure to prevent the onset of disease. If given after that, up to 14 days later, vaccination may reduce the severity of the symptoms, but it won't be as successful at preventing actual infection and disease. The CDC is currently not encouraging mass vaccination for the general public or for all sexually active people, although in certain jurisdictions, consideration of monkeypox vaccine as PrEP for individuals at increased risk of monkeypox from non-occupational exposure might be considered, but should be part of a broader strategy for preventing transmission of monkeypox. Then lastly, I'll say a word now about intradermal vaccination. Studies done a decade ago, actually, by one of our infectious disease fellows, together with colleagues of mine at Brigham and Women's Hospital, showed that intradermal vaccination with modified Vaccinia Ankara vaccine, ACAM 3000, which is very similar to the Jynneos vaccine, resulted in similar immunogenicity at lower doses compared to subcutaneous or intramuscular dosing. So there's now a revised emergency use authorization for the Jynneos vaccine that allows administration of just 0.1 milliliters intradermally instead of 0.5 milliliters subcutaneously, essentially expanding up to 5-fold the available stocks of the Jynneos vaccine. One caveat here is that the vials that were produced were not really manufactured with the intention of being multiple dose vials. And so once entered, the vial has to be used within 8 hours. That's not a problem at sites that are doing a large volume of vaccination per day. But if only a handful of people are vaccinated, that could lead to some wastage of the vial. And therefore, one might consider just using a standard dose if the vial would otherwise have to be discarded. So I hope this information has been useful and look forward to the panel discussion.